We are now back to good old-fashioned chemotherapy with the topic of maintenance therapy. So my financial disclosures. So this was supposed to be a talk on guideposts. So when we're talking about maintenance therapy, which direction do we go and for how long do we keep headed in that direction? And hopefully we'll do it in a vehicle better than the one shown here. Fortunately, we've got the NCCN guidelines that kind of really tell us what we're supposed to do in this setting. And remember, this is for patients who on their first-line chemotherapy have had either responded or had stable disease. And of course, we break it down by histology. So if they're non-squamous, you simply do this. Okay, so that's not so simple. You've got your choices of either continuation maintenance with Bevacizumab, Pemetrexed, Bevacizumab and Pemetrexed, or gemcitabine, although that's a Category 2B recommendation. The others are Category 1. Or you do switch maintenance, a Category 2B, to Pemetrexed or Erlotinib, or you do close observation. Perfectly clear. How about squamous? Well, same kind of thing. You could do continuation maintenance or switch maintenance, or you could do close observation. So unfortunately, I think the NCCN guidelines don't really lead us in any clear direction, and hopefully I'll be able to clarify some of this for you today. There is one thing we know not to do, and that is to continue the original platinum-based regimen until disease progression, and that was shown by a series of studies shown here, where a platinum-based regimen was given for a certain defined period of time, or a longer period of time, or until disease progression. And while these studies do often show, as the one on the bottom that looked at platinum and gem or platinum and a taxane for 2 cycles, and then either 2 or 4 more, depending on whether these patients had a progressive disease or responding, that showed an improved progression-free survival, but none of these studies ever showed an improvement in overall survival. So for that reason, it had been considered standard of care to give between 4 and 6 cycles of platinum-based chemotherapy and then stop until the maintenance studies came in. So what should you do? And I've put little icons because it can get confusing, these studies. Should we stop chemotherapy after 4 to 6 cycles and just observe patients? Should we continue a portion of what they already got until progression? Or should we switch to something entirely different? So all of these potential strategies have their advantages and disadvantages. Observation, what are the pros of that? Well, it had been the standard of care, as I mentioned. It's certainly the easiest, it's the cheapest, and the least toxic. The problem is that patients then may face undertreatment of potentially effective therapies. There are agents with established second-line benefits, and they're becoming more all the time: Docetaxel Pemetrexed, Erlotinib, and now PD-1 inhibitors. Historically, when we try to get patients to second-line chemotherapy after first-line, only 40 to 50% of patients are able to go on to second-line therapy. And for this reason, earlier treatment may be better. It may expose more patients to effective therapy. What are the pros and cons of switch maintenance? And you can also call this early second-line therapy. Well, the pros are that patients get a guaranteed exposure to second-line treatment. The cons are that patients get exposed to the toxicities of 2 separate regimens, and there's potential for cumulative toxicity and certainly inconvenience for patients. Nevertheless, this is one of the first studies that was looking at the switch maintenance study, and I would argue one of the best designed. Patients with advanced non-small cell lung cancer received 4 cycles of carboplatin and gemcitabine. Those who progressed were taken off study, whereas those who had not either got immediate docetaxel or delayed docetaxel plan for progression. Now, one of the things that's important to note when you're looking at these maintenance studies is how many of the patients go on to maintenance. In this study, there were 566 patients that were initially enrolled, but only 309 actually made it to randomization. The rest went off for progression or for toxicity. And interestingly, while patients who were supposed to get the delayed docetaxel at progression, only 63% of them randomized on that arm actually went on to get any docetaxel, and that's going to be an important theme as we look at these studies. This study showed that there was an improved progression-free survival for patients who got the immediate docetaxel, but that's not a surprise. What it did not show was an improvement in overall survival, although there was a trend. The median overall survival was 12 months for those who got the immediate docetaxel versus 9.7 months who got delayed. Didn't quite reach statistical significance with a p-value of 0.085. And then when an analysis was done to look at those patients who actually did go on to get the docetaxel, there was no difference in the survival. So the patients who immediately got docetaxel versus those who got docetaxel at some point did equally as well, suggesting that as long as you're exposed to the docetaxel, you'll do just as well. But not everybody got the docetaxel. And why was that? And one of the great things about this study is they actually analyzed in those 58 patients who were supposed to get docetaxel but never did. Why was that? The majority is for disease progression. Others patients decided that they didn't want it, and there was a smattering of other reasons. Now, maybe this is because they just weren't being followed close enough, and if we had just followed them closer, then they could have gotten to docetaxel and not been too sick for treatment when they got there. But the study actually had a pretty rigorous follow-up plan. There was a plan for physical exam, labs, toxicity assessment, and quality of life assessment every 3 weeks until disease progression, and scanning every 3 months until then. So I think that's a pretty rigorous follow-up in those patients. So then this was the other study that really put switch maintenance on the map. And in this study, patients who had gotten prior platinum-based chemotherapy, 4 cycles of a platinum agent with either gem, docetaxel, or paclitaxel, were randomly assigned in a 2-to-1 randomization to pemetrexed or to placebo. And this was before we knew that it was not a good idea to give pemetrexed to squamous patients. This study showed an impressive progression-free survival in the non-squamous patients. But more importantly, in the overall group, it showed a statistically improved overall survival in the overall group, even including the squamous. The hazard ratio for switch maintenance was better for those patients who had stable disease at induction versus those who had a better response, a PR or a CR. If you look at the overall survival broken up by histology, this is where things really seem to get exciting. For the non-squamous patients, they had a 5-month improvement in overall survival if they got the maintenance pemetrexed, with a median survival from randomization of 15.5 months. Now that seems extraordinarily impressive, but I want to remind you that this study actually started for patients after they'd already received their platinum-based chemotherapy. So we do not know in this study how many of them fell off. So this is a selected patient population, those who are already doing well after their first-line chemotherapy. So it's hard to make any conclusions about this strategy for a patient population as a whole. There is, of course, a cost to maintenance pemetrexed, and that is in the toxicities. If we look just at the grade 3-4 toxicities, though, those toxicities are pretty low. So it seemed like that they didn't have a lot of grade 3-4 toxicities. But remember, when we're talking about a treatment that patients are going to stay on indefinitely, we're concerned about all the toxicities. And there was extra fatigue in those patients who were getting the pemetrexed, as well as anemia and additional nausea and vomiting, as you would expect. Fatigue was the big one there. Only though 5% of patients discontinued for toxicity, and most patients actually tolerated this treatment quite well. Another important thing to consider when we're looking at these maintenance studies, especially those that show an overall survival advantage, is the patients in the control arm. Did they get exposed to the treatment once they progressed? And in fact, only 67% of the patients assigned to the placebo arm were able to go on to second-line chemotherapy. So once again, patients are missing out on their opportunity to get second-line therapy. And unlike in the Phidias trial, the one I showed you before, patients did not automatically get pemetrexed at progression, and in fact, only 19% of patients ever got any pemetrexed in this study if they were randomized to placebo. So is that great benefit that we're seeing, is that due to maintenance pemetrexed, or is that due to any pemetrexed at any time? Another switch maintenance study is the Saturn study. This was looking at maintenance Erlotinib in unselected patients who had gotten 4 cycles of a first-line platinum-based doublet. These are the numbers of the patients that made it to randomization. The overall survival was better by a hair on the Erlotinib arm, 12 months versus 11 months. It was statistically significant. If you look just at the immunohistochemistry EGFR positive patients, they did a little bit better. Surprisingly, there was not an overall survival benefit in the mutation positive patients, though that was likely due to crossover. These patients could be salvaged by an EGFR TKI later. There was some benefit in terms of analgesic use and pain for the patients who went on the maintenance Erlotinib. So here are the progression-free survival and overall survival graphs. And what they also saw here is that patients who only had stable disease did better if they went on to Erlotinib rather than those who had had a CR or PR to their initial chemotherapy, indicating that these strategies probably are best for the patients who may be not progressing to the point that we're seeing it on the scans, but the chemo didn't work very well for them, and there's the ones who really do benefit more from early second-line therapy. When they break it up by the mutation-positive patients, this is what we saw. The EGFR-mutated patients, while not having an overall survival benefit, had a very dramatic progression-free survival benefit when they got the Erlotinib as maintenance. The KRAS-mutated patients did not seem to benefit, which makes sense. So again, there were the toxicities that you would expect from EGFR TKIs. The patients who got the maintenance Erlotinib were more likely to have rash and diarrhea. And once again, if we look at the percentage of patients who got additional therapy in the placebo arm, only about, once again, 2/3 of patients went on to get second-line therapy, and only 21% went on to get any EGFR TKI. So now on to continuation maintenance, as opposed to switch maintenance. What are the pros? Well, when you do continuation maintenance, there's no new toxicity. They're getting a portion of what they've already had, so you should be aware of how they're going to tolerate it. It also ensures the maximum benefit of the treatment that you're given. You're really squeezing everything out of that treatment so that you're not ditching a treatment before it stopped being effective. The cons, there is cumulative toxicity to these agents, and also when the patients do progress, if they've been on maintenance therapy, they may not be in as good shape for the second-line therapy when it's time to go that route. So there are drugs that we give as continuation maintenance just because we've always done it that way. In fact, we've never actually proven that it's beneficial. Certainly the oral agents are given until disease progression, and we do have good data that if you stop it, the disease can flare, so that's certainly a good idea. But then Bevacizumab, Cetuximab, Nivolumab, those are also given until disease progression. This was ECOG 4599, the study that showed that the addition of Bevacizumab to chemotherapy improved overall survival, and patients were maintained on the Bevacizumab alone until disease progression after initial 6 cycles of chemotherapy. There was an attempt to do an analysis to see if that maintenance Bevacizumab actually made a difference. This was done by looking at the patient populations who made it past their 6 cycles of chemotherapy. And indeed, in that population, it seemed that the patients who got the Bevacizumab had an improved progression-free survival and maybe a little bit better overall survival. Doing the analysis from maintenance was an attempt to level the playing field and see how much the maintenance Bevacizumab actually contributed. I personally don't think it's a fair comparison. You don't know that those are the same patients who are getting to maintenance, and they could still be benefiting from their differential induction strategy. So I don't think this really proves that maintenance Bevacizumab is superior to not doing it. Similarly, the FLEX trial, which was chemotherapy with Cetuximab, also used maintenance Cetuximab until disease progression, as did Nivolumab. So now looking at Pemetrexed as continuation maintenance, this was a study where patients got cisplatin and Pemetrexed, and those who did not progress were randomly assigned to continue the Pemetrexed in a 2-to-1 randomization or get placebo. 57% of patients were able to go on to maintenance in this study. The median range of treatments was 4 in both groups. So the primary efficacy endpoint was progression-free survival, and there were 2 different analyses, but they both showed that the progression-free survival was dramatically better in patients getting maintenance. But most importantly, for our purposes, the overall survival was also improved in patients who got maintenance Pemetrexed. And this was the overall survival from induction. The median survival from induction was 16.9 months in those patients getting Pemetrexed. But remember, this is a selected patient population because this is not the whole group who were on the study. This is just the patients who made it to maintenance. And so here are the hazard ratios. So one thing, when you do maintenance, you don't see that same differential benefit for those patients who had stable disease with induction versus those who had a CR or a PR. Once again, we see that there is toxicity to continuing chemotherapy, and mostly it's fatigue. And for patients getting additional therapy afterwards, once again, only about 2/3 of patients in the placebo arm were able to get additional therapy. And again, with 64% in those who got maintenance Pemetrexed were able to go on to additional therapy. So there have been a lot of other studies looking at continuation maintenance chemotherapy with either gemcitabine or docetaxel, and those are shown here. There are studies looking at platinum and gemcitabine. The first one listed shows a progression-free survival benefit, but none of these show an overall survival benefit. The second one didn't even show a progression-free survival benefit, but those patients had very poor performance status. There was a study looking at the maintenance gemcitabine versus Erlotinib, and once again, that did not show a survival benefit. And then the last one is a Chinese study that actually looked at cis-docetaxel induction followed by maintenance docetaxel at a reduced dose of 60 milligrams per meter squared, and it showed a very impressive progression-free survival, but did not show an overall survival. And of course, the toxicity is greater in any patients maintained on cytotoxic chemotherapy. What about continuation maintenance with pemetrexed and bevacizumab? Well, that was looked at the AVRPEARL study. Patients got pemetrexed, bevacizumab, and cisplatin, and those who did not progress were randomly assigned to bevacizumab or the combination of pem and bev. And 67% of patients went on to the maintenance. This showed a very impressive progression-free survival for those who were on the pemetrexed in addition to the bevacizumab. That was the primary endpoint of the study. It was not really powered for overall survival, and indeed there was not a statistical benefit in terms of overall survival, maybe a hair better for the PEM and BEV, 17 months versus 13 months, but again did not achieve statistical significance, but was underpowered. Once again, patients who were maintained on cytotoxic chemotherapy had more in the way of fatigue, neutropenia, and anemia, just more toxicity in general. So some of these questions will be answered, what our best strategy is in this ECOG study, which is a study of carboplatin, paclitaxel, and bevacizumab, and patients who do not progress are randomly assigned to either get maintenance bevacizumab, as was done in the initial ECOG 4599 study, switch maintenance to pemetrexed, or continuation of the bev and switching to the pemetrexed as a maintenance strategy. This is not really a study, the Point Break study, that was testing two different maintenance strategies. It was testing different induction strategies, but I think is important to mention in this context. This was looking at the 4599 strategy of carboplatin, paclitaxel, bevacizumab versus a pemetrexed carboplatin, bevacizumab regimen. The maintenance strategies were different. In the PEM arm, the bevacizumab was continued, whereas just the bev was continued in the taxane arm. There was no difference in overall survival in the study. Both strategies were equally efficacious in terms of overall survival, and there was no one group that benefited more than the other in either direction. There was an improvement in progression-free survival for those on the pemetrexed arm. I don't think that's much a surprise. They continued on a cytotoxic chemotherapy regimen, so I think that's what we would have expected. There was an analysis, again, from maintenance to try to tease out which maintenance strategy was better, and in that setting that there was a very much improvement in progression-free survival for those who got the combination maintenance versus just the bevacizumab, and a suggestion of an overall survival benefit for those patients. But I would want to point out that this means if the overall survival for the strategy for the group as a whole was the same, but then of those who make it to maintenance, they do better on the pemetrexed arm, well, that suggests that something was happening during induction that they didn't do better overall. So this is the this is the treatment on when they finished their treatment, and again, only about 2/3 of patients went on to additional treatment. One of the interesting things about looking at these studies is you get to try to figure out which induction strategy may have gotten more people to maintenance, and I've highlighted in pink the patients who were getting a bevacizumab-based regimen, and it does seem like they were more likely to get to maintenance versus those patients treated on studies where bevacizumab was not a piece of it. There are ongoing studies looking at maintenance strategies. There is actually a French study that is looking at whether or not switch maintenance or continuation maintenance is better. The control arm is the paramount regimen of cis-PEM followed by PEM maintenance, or for patients who do not, or a strategy of cisplatin and gemcitabine, and then a strategy of gemcitabine continuation if the patients respond, or switching to pemetrexed if the best response is only stable disease. There is a study looking at maintenance Erlotinib at progressive disease. So this is a study that's like the FIDEUS study. Patients either get immediate or delayed Erlotinib at progression. There is a French study looking at patients over the age of 70, looking at carboplatin and paclitaxel for PEM in non-squam, gem is squamous versus surveillance for elderly patients. There is a study looking at nab-paclitaxel in squamous patients, followed by nab-paclitaxel or observation maintenance. And then there was a Norwegian study that's looking again at the issue of maintenance pemetrexed, where patients either get pemetrexed maintenance or guaranteed pemetrexed at progression. This kind of will help us tease out, is it pemetrexed immediately or any pemetrexed that makes the difference? So my final thoughts. What is the best maintenance strategy? Well, it depends on your initial regimen. It also depends on the patient. How did they tolerate their initial treatment, and what are the patient's goals and priorities? It also depends on whether costs should be something we should be factoring in. This maintenance PEM-BEV really does break the bank in terms of how much it costs. So for oral agents, bevacizumab, cetuximab, nivolumab, you certainly continue those until progression or until they're not tolerated. If a patient is on a pemetrexed-based regimen and tolerating the pemetrexed well, then I would strongly consider continuing the pemetrexed until progression. What do you do in patients who got both first-line pemetrexed and bevacizumab? Well, that's less clear. Bevacizumab alone is clearly the best tolerated strategy, and there's no evidence for stopping the bevacizumab, but continuing the pemetrexed will improve your progression-free survival, less clear that it improves overall survival. And for patients who are started on a non-pemetrexed chemotherapy regimen, would strongly consider switching to pemetrexed if they're eligible at the completion of their platinum-based chemotherapy. And those patients who only had stable disease are most likely to benefit from a switch maintenance strategy. Thank you.